International NGOs are expensive. They're usually run from their headquarters in expensive cities of high-income countries like Washington, D.C., or New York, or Boston, or Seattle, where the costs are quite high compared to low-income countries. They charge overhead, indirect costs for their offices and overall organizational administration, which are not related to the specific grant or contract. And the overhead can be more than half of the entire project budget, with an average between about 15 to 30% of these total budgets. The INGO offices are often quite expensive, and the administrative staff typically earn high salaries for overall management of the NGO. In addition to the overhead, the INGOs have substantial headquarters staff who provide either technical or financial management support just for the specific project. They're also highly paid, and they take additional funds from the project budget. They supervise the extensive and stringent programmatic and financial reporting requirements from the donors, and these staff can easily consume another 15-30% of a grant that's ostensibly allocated to a given low-income country. So, overall, between 30 and 60% of the total budgets of many global health aid projects never even leaves the headquarters of the INGO. Furthermore, within the low-income country that's supposed to be the beneficiary of the aid, the INGO typically has well-appointed, nicely equipped offices with technical administrative staff whose salaries and benefits greatly exceed those of the government counterparts, often up to 10 times greater than local salaries. They typically have fleets of relatively new and expensive 4x4 vehicles to oversee project activities and attend meetings with their government counterparts and other NGOs. And a big piece of the INGO activities involves short-term trainings of government health workers, including paying per diems to these government health workers that amount to up to a third of their monthly salary per day of training. The INGOs also need armies of financial, human resources, and data analysis to manage the projects. And some of these trainings are quite effective, but others are less so, especially since the Ministry of Health budgets are so grossly inadequate that they result in poor working conditions, poverty salaries, and low morale. It's no surprise that Ministry of Health workers often struggle to carry out the activities they're trained to do by these NGOs. In Mozambique, for instance, the total PEPFAR budget in 2016 was approximately $450 million, almost as much as the total Ministry of Health budget of $472 million. And although the PEPFAR budget covered the costs of much needed and expensive HIV viral load testing and equipment and medicines and supplies, all used by the MOH, the bulk of the $450 million went to the INGOs and to the very large PEPFAR technical administrative staff and their associated costs. Many highly trained technical staff from the Ministry of Health left their jobs to take advantage of the much higher salaries and benefits and the working conditions of the INGOs and the PEPFAR offices, creating huge gaps and critical positions within the Ministry of Health throughout the country. The Ministry of Health leadership has complained bitterly about this internal brain drain, but little has been done. According to my sources within the Ministry of Health, less than 5% of the total PEPFAR budget went directly to the Ministry of Health, where the funding needs have been the greatest. The exact amount of phantom aid in a country like Mozambique is difficult to ascertain, but my guess is that the true value of the aid to the Ministry of Health, calculated by the proportion of what the total project budget would likely have funded had it been managed through the Ministry of Health, is about 20 to 40%. So, even if the Ministry of Health lost 10 to 20% of donor money through, say, mismanagement or corruption, which by the way also happens in INGOs, this would be far, far less than the legal loss of 60 to 80% of the value of this through the phantom aid process. Phantom aid also perpetuates inequality by creating a class of elite nationals and expatriates whose donor-funded salaries push up the overall costs of housing, food, vehicles, and the INGO vehicles are big contributors to traffic jams and environmental crises. So these characteristics of global health aid are apparent to many well-intentioned NGO global health workers, but they're reluctant to examine this diversion of funds in their agencies, or to themselves, or to examine our own roles in perpetuating the inequality. This is not an argument to reduce global health aid to low-income countries. They need support and solidarity and financial resources from the global north. But there are much better ways to work with ministries of health to improve systems for the poor and disenfranchised. We could start with direct contributions to ministries of health, whose capable staff are likely to use these contributions in a much more efficient manner, including hiring out NGOs, and then they can decide which NGOs to work.